Terminology. Every profession has their own language that they speak to each other, no matter whether it's professional athletes, plumbers, electric workers, or medical workers. We all have that special language that we use to communicate with each other. So as EMTs, you will need to know how to speak the language, how to understand what people are saying when they're talking to you, and how to communicate the different terms back and forth to the other medical professionals we have to deal with. So we're going to start off talking about the terminology. Basic understanding of medical terminology is words are made up of two or more parts. A lot of times we take smallpox, it's a relative, small is the best word you can use, I guess, and it's a pox, it's a blister, so smallpox. We use that different ways to try to figure out how the different words that people use when we're talking. So we use the root word. We'll take thermometer here. Therm means heat. Thermometer, a meter measures things, so we have a thermometer. So we have a meter that measures heat. We also have a couple prefixes that we need to know about. Dis, tacky, Brady, app. Dis means difficulty, tacky means fast, Brady means slow, app means without. Then we throw those onto nia, which is breathing. Dyspnea is difficulty breathing. Tachypnea, tachypnea is fast breathing. Bradypnea is slow breathing. Apnea is not breathing. And we look at the suffixes. Itis, inflammation, arthritis, inflammation of the joints. Hemophiliac, iliac, iac means difficulty with, so difficulty with the blood. We can take it even farther and take the cardiologist and break that down. So you're not really sure what a cardiologist does. The first part is cardio, which means heart. Ology is the study of. So cardiologist is somebody who specializes in it. So procto means lower digestive system. So a proctologist is one that just studies the lower digestive system. So it gives you an idea of how to kind of break things down when people tell you different words here. We also have an unusually high number of abbreviations within our group, within the medical community. So we need to understand the abbreviations, understand the right abbreviations to use, and how they could be misinterpreted by other professions. When in my job at utilities, we have water treatment facilities, WTFs. Some people confuse that with other versions of WTF. So water treatment facilities, sometimes we have to refer back as water treatment plants, WTPs. CPAP, continuous positive airway pressure. You'll hear it called CPAP more than anything. So SOB, shortness of breath, also has other meanings. So we need to be aware of acronyms. They're great for using when we are documenting what's going on with our patient. It helps us understand what we're talking about without writing out the whole word. So it comes into play, and we just need to be aware of those. So we'll study several of those as we go along here. Cholecystitis, taking this back, breaking it down. Chole means bile. Cyst means sac. So itis, bile sac inflammation. Cholecystitis, or inflammation of the gallbladder, which stores the bile. So kind of how we break down words. There are many books on medical terminology. They have classes in that medical terminology at the different college level for the medical programs. So it's very important that we understand how to kind of break down words and understand what other people are talking to us. Think about who your audience is. If you ask the patient if they have an epistaxis, they probably won't know what epistaxis is. But don't underestimate your patients. Some of our special needs patients, people that have chronic illnesses, probably understand their diseases and the medical terms that go with them much better than you ever thought they would. When my son was probably 4 or 5, we did a barometric checkup program at the zoo with him, and the paramedic told him that the EKG takes a picture of your heart. And he corrected her and said, no, it examines the electricity in the heart. So you never know what the patient might understand. So think about that. Maybe say, or do you have an epistaxis, or we'll commonly called a nosebleed? That might be a good way to do it and not disrespect the patient, but actually give them credit for possibly knowing things. Well, the other thing we need to make sure is we're using the correct term at the right time, because we want to get our communication as close to accurate as possible so that we don't have issues when we're talking to our patients or transmitting the medical information to the next caregiver. It's as simple as right and left. If you say the patient needs to have surgery on their left ankle and we get that mixed up, they end up having surgery on the wrong ankle. So language of anatomy and physiology, these are kind of ways we're going to talk about the body and how it interacts with each other. So anatomy is the structure and physiology is the function. So we're going to, throughout the class, we're going to talk every disease process that we can think of, talking about how it affects the anatomy and the physiology both. So anatomical terms. When we talk about anatomical terms, it's the way we reference parts of the body and locations in the body so that everybody knows the same information we're talking about. If I tell you to go to the top of the map, most people understand that's north. But we need to have that with the body. We need to identify the north no matter what direction the map's facing. So we're going to use normal anatomical position. That's standing upright, hands facing forward, arms down to your side. That's normal anatomical position. So if we use that as our starting point on how we're describing a patient. We have the body divided into multiple planes. We have front, back, left, right, anterior, posterior. We have upper and lower. When we're talking about the midline of the body, that's right down the center, dividing it left to right. Medial is a directional term for us, means closer to the midline. Lateral means farther away from the midline. So I would say my patient has a laceration 2 inches lateral to midline. Or I have a wound that's going from 5 inches lateral towards the midline, medial 2 inches. So we're using it as kind of like a reference point in directional terms like left and right, north and south, east and west. Bilateral, both sides. Unilateral, one side. So we've got a bilateral fractures to the arms. So both arms are broken. Unilateral, the opposite. Mid-axillary line. Like we add more reference points. Mid-axillary goes right down the center of the clavicle and divides the body another kind of into 4 quadrants. Now you've got left and right of the mid-axillary line, and then you've got the midline down the center. Anterior is front, posterior is back. You sometimes hear those called ventral and dorsal, but that's not a common term anymore. Superior, inferior. Superior means going towards the top, inferior means towards the feet. So use those as references here. Proximal, closer to the torso. That is used for your extremities. So I have a laceration 2 inches proximal of the elbow. That's on the upper arm. Distal means farther from the torso. Palmar is the palm of the hand. Plantar is the sole of the foot. Palm is the palm. Plantar fasciitis, you've heard of that one, I'm sure. That just means inflammation of the foot and the bottom of the foot. So here's a directional term example. This is in your book also. Shows all the different major body parts and how we're kind of dividing it up. So you need to understand the cranium, the face, the thorax, the abdomen, the pelvis, and parts of the extremities, the arms and the legs. This example is also found in your book. It shows you the directional terms we're talking about. So you've got your midline dividing right and left. And just remember, it's the patient's right and left, not yours. And then anterior, posterior, you got a midline down the center of the head, right about the ears, and divides the body into front and back. So we're going to use these terms as we're describing locations on our patients. We're going to describe them on how the injuries or illnesses are affecting our patients. So it's the time you need to start memorizing these and understand how they work. Big clavicular line, we talked about that, divides the chest into regions. So I go right down the center of the clavicles, and that's one reference point we're going to use for identifying locations for EKGs. So you use that. It's also identifying locations when they have injuries to the chest. Because the abdominal cavity has so many different organs located in it, we need to use a little bit more mapping on this one. So we use the umbilicus as our location point to start dividing the abdomen up into 4 quadrants. So we take a vertical line down the midline of the abdomen through the umbilicus, and we divide it left and right. And then we take a horizontal line through the umbilicus and divide it upper and lower. So then we will have the upper right quadrant, upper left quadrant, lower right quadrant, lower left quadrant. We're going to use these as our roadmap when we're describing pain, and we can also know what organs lie in each quadrant and kind of reference back to that when we're trying to identify what the pain source is. So if you take the abdominal cavity, the gentleman on the left, he's got the upper and lower quadrants identified there, right and left. The abdominal cavity stretches all the way superior into the diaphragm, which is just up underneath the edge of the ribs. So it goes pretty far up, and then it goes all the way into the pelvis. So when we're talking abdominal cavity, it's from the pelvis to underneath the ribs. On the right side, it shows where the different organs are. So you've got the liver, parts of the colon, the part of a kidney, gallbladder, pancreas, all kind of tucked up in the upper right. Upper left, you've got part of the liver, all of the spleen, all of the stomach, a little bit of the pancreas, kind of tucked in the upper left there. Lower quadrants, you've got colon, small intestine, arteries, appendix in the lower right quadrant, and then if your patient is a female, you've got the uterus and fallopian tubes and ovaries located in the lower quadrants. Start trying to memorize these. We're going to use these throughout the course on trying to figure out what organs are where, and then we're going to learn what organs do what, and we're going to be able to identify the symptoms the patient's having with the signs we see and identify what the potential problems are. Anatomical terms on how our patient is positioned. If the patient is lying supine, that means they're on their back, laying flat on their back, facing up. Prone is laying on their abdominal, on their front side, facing down. So it's kind of like you see outside the bars on Tejon Street. Recovery, this one you should have learned in your CPR class. Place the patient on the side so if they do vomit, they're not going to choke on their own vomit. This is used for non-trauma patients only. We don't do this for trauma patients. So here's a picture of supine. There's a picture of prone. So that it's important to kind of describe how you find your patients so we can identify the injury patterns associated with how they're found. This is the lateral recumbent. Notice how our arms kind of tucked up underneath her head so her head's not dangling off to the side. Fowlers means they're sitting upright, straight up. Semi-fowlers is a leaning back. We typically call this a position of comfort, and we ask the patient, hey, how high would you like your head? the patient will tell you, and you put them there. Go up a little bit more, go down a little bit more, or get them in the semi-Fowler position they prefer. So any questions you have, write them down, bring them to class, and we're going to talk about them. Good luck. Thanks.